Hi everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Seedra, your host for today's episode, and I'm joined by my Bullous bestie Naya to talk all about skin blisters.
Intil Bullous. Anywho, unlike the blisters you get from breaking in new shoes, the ones we're going to talk about come from deeper issues like autoimmunity, structural defects, or inflammation. They can look frightening, they can be painful, and if you don't recognize the pattern, you're stuck. So we're going to gently peel off the confusion around bullous skin disorders without creating any blistering side effects.
Alright, before we jump into the diseases, let's start simple. What are we actually talking about when we say bullous disorders or blistering diseases?
In dermatology, blisters are the star of the show. They're a little pocket of fluid that forms because the normal glue holding the skin layers together has been disrupted. We classify the different bullous diseases depending on the layer affected.
And I'm guessing different disorders also have different underlying mechanisms?
Yep, they're usually one of two big categories. The first category is autoimmune blistering diseases, where antibodies attack the glue between the cells, whereas the other category is inherited mechanical disorders, where the glue itself is structurally faulty from the start.
Before we get lost in all the diseases, let's pause for a second. If we're going to talk about how blisters form at different levels of the skin, we should probably understand what those levels even are. So, Naya, do you want to walk us through the grand tour of the skin?
Absolutely. Think of the skin as a three-story building. On the top floor, you've got the epidermis, the middle floor is the dermis, and the basement is the subcutaneous tissue, which is mostly fat. Blisters basically form when the walls between these floors start giving out.
That actually makes a lot of sense. What do we normally see on the top floor? Was it the epidermis?
The epidermis is mainly made of keratinocytes, marching upward through four layers. The basal layer at the very bottom where cells divide, then the spinous layer where they start toughening up, then the granular layer where they pack themselves with keratin, and finally the corneal layer, which is basically a layer of flattened dead skin cells acting like armor.
It's like a slow escalator of skin cells. The interns step at the bottom and ride up until they retire at the top.
Exactly, and they aren't alone. You have melanocytes giving pigment, Langerhans cells acting as security guards for the immune system, and Merkel cells handling touch sensation. They're all part of the epidermal squad.
Okay, so that's the top layer. But blisters aren't just random. They happen because something goes wrong with the connections between these cells. So, Naya, can you go over the pathophysiology?
Right. Inside the epidermis, keratinocytes hold hands using structures called desmosomes. These desmosomes are made of special proteins called desmoglians. Their names are pretty much similar, so that makes it easy to remember. Desmoglian 1 is mostly part of desmosomes in the superficial layers of the epidermis, while desmoglian 3 is more in the deeper layers of the epidermis, closer to the basement membrane, as well as in the mucosa like in the mouth.
I see. So when autoantibodies attack desmoglian 3, you break apart the deeper epidermis in both the skin and mucosal surfaces. And that explains why pemphigus vulgaris, which we will discuss in detail, also affects the mucosa in the mouth.
Yes, exactly that.
Okay, so what's happening under the epidermis?
That takes us to the basement membrane zone, basically the border control between the epidermis and the dermis. It's super important because it physically anchors the epidermis to the dermis.
So without it, the top layer would just peel off. Yikes.
Exactly. The basement membrane zone has specific components. First, you have hemidesmosomes, the structures that anchor basal keratinocytes downwards. Then, the lamina lucida, which contains BP180 and integrins, the exact proteins that bullous pemphigoid antibodies attack, as we will see in a bit. After that is the lamina densa, made of laminin 332 and type 4 collagen. And finally, the sublamina densa, where you have the anchoring fibrils made of type 7 collagen.
So pemphigus attacks desmosomes, while pemphigoid attacks hemidesmosomes and basement membrane structures.
That can be confusing at times, but once you understand who's holding on to what, all these diseases suddenly make perfect sense.
So far, we've covered the epidermis and the basement membrane. But what about the dermis?
The dermis is the supportive middle layer. Tons of collagen, elastin, nerves, blood vessels, hair follicles, sweat glands, and sebaceous glands. It's basically the infrastructure layer that supports everything above it. Finally, under that, the subcutaneous tissue is mostly adipose. Insulation, cushioning, energy storage, which are some of the benefits of adipose tissue.
So from top to bottom, we have epidermis with its layers and cell types, basement membrane with its attachment proteins, dermis with its structural and sensory components, and subcutaneous fat cushioning everything.
As you said. And blisters form when any of those connection points, desmosomes, hemidesmosomes, basement membrane, or anchoring fibrils, fail. That's why understanding the structure is the key to recognizing every blistering disorder.
Before we dive deeper, I feel like dermatology has its own language that I personally do not speak. All these words, vesicles, bulla, can we talk about what they actually mean?
Yes, absolutely. Dermatologists basically communicate using morphology. It's like the native language of skin. It doesn't tell you the cause of the condition, it just describes what you're seeing with your eyes.
So, step one is learning how to describe what's actually on the skin.
Spot on, Seedra. First, we have a term called primary skin lesions, which refers to the original characteristic lesions of a disease. Examples include macules and patches, papules and plaques, pustules, nodules, cysts, vesicles, and bulla, petechia, purpura, ecchymoses, wheals, and even barrows, you name it.
And of course, vesicles and bulla are our focus for this episode.
Yup, a vesicle is less than 1 centimeter, elevated, circumscribed, and filled with clear fluid. A bulla is the same thing but more than 1 centimeter. Same idea, just different size.
So, vesicles and bulla? Why do we keep saying blister if it's not even in this dictionary?
Funny thing, blister isn't technically a primary lesion name. It's just a general term people use to describe either a vesicle or a bulla.
Since we just discussed primary lesions, I'm assuming there are some secondary ones? What are those like?
Those are changes that happen to the primary lesions because of scratching, inflammation, trauma, or just a natural evolution of a lesion. Examples are excoriations, erosions, ulcers, fissures, crusts, scales, atrophy, lichenifications, and infarct.
So, primary is how the disease presents, and secondary is how those primary lesions change due to external factors. I'm guessing the secondary lesions relevant to blistering disorders are erosions and crust?
Pretty much, yeah. An erosion is a partial loss of epidermis and it heals without scarring. A crust is basically dried serum or blood, usually after a vesicle or bulla ruptures.
So that describes what we're seeing. But Bullous disorders also depend on the skin layer where the blister forms, right?
Absolutely. First, we have subcorneal and intraepidermal blisters. These happen above the basement membrane zone because of problems inside the epidermis, especially with desmosomes. That's the pemphigus group.
Okay, so subcorneal and intradermal blisters. Did you just forget about subepidermal blisters?
Oh yeah, that totally slipped my mind. Subepidermal blisters, which happen at the basement membrane zone when anchoring structures like BP180, laminin 332, integrins, or type 7 collagen are disrupted. All those basement membrane components. That's what we see in bullous pemphigoid and the inherited epidermolysis bullosa.
And just to clarify to our dear listeners, not every blister equals a bullous disorder, right?
Yes, many conditions cause blistering but aren't classified as bullous diseases, and these are actually the more common causes of blisters in our everyday life. For example, acute dermatitis, bullous impetigo, herpes infections, burns, insect bites, even physical trauma, like from an uncomfortable pair of shoes. Those are blistering reactions, not true bullous disorders.
So today, our focus is on the autoimmune and inherited ones.
Exactly. Those are the ones attacking or disrupting the structural proteins that normally keep the skin layers together.
Okay, before we dive into the actual diseases, I heard clinicians love doing little bedside tricks with blisters. You always hear about those special signs. Nikolsky and something Hansen? What are those?
Yes, these are super practical. The Nikolsky sign is when you apply gentle lateral pressure on the skin and the epidermis actually slips off. That basically means the skin cells aren't holding onto each other well. It's a classical sign in pemphigus.
So, just pushing on the skin would make it peel?
Exactly. The other sign is the Asboe-Hansen sign. This one is also called the Bullous spread sign. You press gently on the top of an intact blister, and instead of just sitting there, the blister actually spreads further underneath the skin. That's also a hallmark of Pemphigus vulgaris.
So, lateral pressure makes it peel, and downward pressure makes it expand, both pointing towards pemphigus.
Right. I recommend you look up a video of these signs and you'll never forget them after.
Okay, now that we fully understand the basics of the skin, I think it's time for our first case of the episode. A 52-year-old woman presents with painful erosions in her mouth for the last few months. She then started noticing flaccid blisters on her chest and back that rupture easily, leaving raw, crusted erosions. When you examine her, even gentle pressure on normal appearing skin makes it slough off. demonstrating a positive Nikolsky sign. What diagnosis should pop right into our heads?
This is classic for Pemphigus vulgaris, the prototype of intraepidermal acantholytic blistering disease. Pemphigus is a group of autoimmune diseases where the body makes IgG autoantibodies against the desmosomes. Those are the little proteins that hold keratinocytes together in the epidermis, almost like screws.
So these desmosomes get unscrewed in pemphigus?
On the nose, Seedra. And the key molecule is desmoglein, which, as we said, can be one of two types, desmoglein 3 in the lower epidermis and mucosa, or desmoglein 1 in the upper layers of the epidermis.
So think of it as the bigger the number, the lower it sinks. That's why desmoglein 3 is in the lower layers, while desmoglein 1 is in the upper layers of the epidermis.
That's a brilliant way to put it. In Pemphigus vulgaris, the antibodies mainly target desmoglein 3.
That means the lower parts of the epidermis and mucosa lose cohesion. The mucosal involvement by desmoglein 3 is why pemphigus also affects the mouth.
صح عليكي. Under the microscope, you see something called acantholysis. Basically, the skin cells let go off of each other, become round in shape, and drift inside the blister. The split happens just above the basal layer, so it forms what we call a suprabasal blister, aka above the basal layer, so still in the epidermis.
And this creates the classic appearance of a tombstone row.
Yes, when the suprabasal part lifts off, the basal keratinocytes are still attached to the basement membrane. So in histology, they look like a row of little cells standing alone on the basement membrane like tombstones.
So is the dermis affected in pemphigus?
The disease in pemphigus is by definition in the epidermis, but you could see some superficial dermal infiltrate made of lymphocytes, histiocytes, and eosinophils. So it's just an inflammatory reaction to all the antibody drama happening above.
I remember you mentioned IgGs. How are those detected under immunofluorescence?
Since the antibodies are sitting on those desmosomes between the cells, with direct immunofluorescence for IgG, we see a fishnet or chicken wire pattern of IgG deposits between keratinocytes through the epidermis. In Pemphigus vulgaris, the staining is often seen at all levels, unlike the other types of pemphigus, such as Pemphigus foliaceus, which is more superficial since it targets mainly desmoglein 1, as we will see in a second.
So in Pemphigus vulgaris, the staining is often seen at all levels of the epidermis, creating a fishnet appearance on immunofluorescence. Okay, let's go back to our patient. She's in her 50s with mouth ulcers and flaccid blisters that rupture easily.
This is the typical age and presentation of Pemphigus vulgaris, which usually affects adults in the 4th to 6th decade and affects both genders equally.
We just covered the underlying mechanism and pathological findings in Pemphigus vulgaris. Let's quickly talk about how these patients present clinically.
Of course, you'll almost always find mucosal lesions, especially oral ulcers, and these can show up months before the skin gets involved.
So it starts in the mouth and then eventually affects the skin as well.
Kafu. The blisters in Pemphigus vulgaris are really flaccid because the roof is so thin so they pop easily. That's why instead of perfect blisters, patients usually have painful, raw erosions with serous crusting. And because the skin so easily separates, if you apply pressure to it, you observe positive Nikolsky and Asboe-Hansen signs. The common sites of skin affected in this condition are the scalp, face, axilla, groin, trunk, and pressure points.
So, if you see mucosal erosions plus flaccid blisters, positive Nikolsky and Asboe-Hansen signs, suprabasal split, and fishnet IgG on direct immunofluorescence, think Pemphigus vulgaris.
Perfectly summarized. By the way, it's not just cosmetic. Untreated, pemphigus can be fatal because of fluid loss, infections, and being in an overall catabolic state. That's why we treat with immunosuppressive drugs like systemic steroids and other agents to reduce those autoantibodies.
Alright, so vulgaris is the big one, because the term vulgaris just means common. But the Pemphigus family has a few siblings like vegetans, foliaceous, erythematosus, and perineoplastic pemphigus. Do you want to walk us through them?
Sure. Let's start with Pemphigus vegetans. It's basically vulgaris, but with a twist. You still get the suprabasal acantholytic blister, but clinically it shows up as big, moist, warty plaques in flexures areas like the groin and the axilla. Under the microscope, it's the same suprabasal split, just with extra epidermal growth that creates that vegetating look.
Aha, so we call it vegetans because it forms these vegetations of the skin? How neat. And what about the other types of pemphigus, like foliaceous?
Pemphigus foliaceus is a milder, more superficial form. The antibodies mainly target desmoglein 1, which sits in the upper layers of the epidermis, so the split happens high up, right around the stratum granulosum, forming subcorneal blisters right under the stratum corneum. The mucosa is usually spared because it relies more on desmoglein 3, which is not targeted in foliaceus. Clinically, you mostly see redness, scaling, and crusting on areas like the scalp, face, chest, and back. The blisters are so superficial and fragile that they almost never stay intact. They just show up as crusty erosions. There is also an endemic version in Brazil called Fogo selvagem.
And that's Pemphigus foliaceus for you. Now,
I know. Next up is Pemphigus erythematosus. This is a localized, milder form of foliaceus, often on the malar area, sometimes with a lupus-like distribution.
so it gets the name erythematosus because it looks like the malar rash you see in systemic lupus erythematosus.
Yes, that's a great way of linking concepts, and that also helps us remember it a lot. The last member of the Pemphigus family is the paraneoplastic pemphigus, which we can easily understand from the name. Paraneoplastic means it's something that happens as a result of neoplasia somewhere in the body. So, in simpler terms, it's linked to underlying cancers, especially non-Hodgkin lymphoma among other tumors. These patients get really severe mucocutaneous blistering, and the antibodies can target multiple adhesion molecules, not just desmogleins.
Okay, let's quickly summarize all types of pemphigus. We have vulgaris, which affects the mucosa and the skin, leading to suprabasal separation and fishnet IgGs at all levels of the epidermis. Moving on to foliaceus, which hits desmoglein 1 at the superficial layers of the epidermis, leading to crusty lesions, and because it doesn't affect desmoglein 3, the oral mucosa is usually spared. Now we have vegetans, which is basically like vulgaris, in addition to vegetating plaques in the skin flexures. We have erythematosus, which is just localized mild pemphigus that affects the malar region. And finally, we have paraneoplastic, which is associated with malignancy, especially non-Hodgkin lymphomas.
That summer really popped off. Get it? Like blisters?
Okay, move on.
Okay.
Okay, moving on, quick check for our listeners. A patient has painful oral ulcers, flaccid blisters on the trunk that rupture easily, and a biopsy shows suprabasal acantholytic blister with a tombstone basal layer and fishnet IgGs on immunofluorescence. So, what's the diagnosis?
The diagnosis is, can we have a drum roll, Seedra? Pemphigus vulgaris.
Exactly. You're absolutely correct. All right, let's leave the pemphigus family now. I've had enough. So, for our next disorder, imagine an elderly patient, say in their late 70s, with big, tense blisters on the inner thighs and lower abdomen. They're itchy, but the blisters don't rupture easily. The mucosa is either normal or mildly affected. What should we be thinking about now?
That's the classic picture of bullous pemphigoid, another autoimmune blistering disease, but this time the antibodies target the hemidesmosomes that attach the epidermis to the dermis.
So in pemphigus, antibodies attack cell-to-cell adhesions within the epidermis, whereas here, they attack cell-to-basement membrane adhesions at the dermo-epidermal junction.
صح عليكي. In bullous pemphigoid, autoantibodies go after BPAG1 and BPAG2, which are proteins in the hemidesmosomes that anchor the epidermis to the dermis. BPAG2 is also known as collagen type 18. When these anchoring proteins are attacked, that connection weakens and the epidermis lifts off the dermis, forming a subepidermal blister.
I see. That explains the tense bulla, because the entire epidermis is forming the roof, so it's thicker and stronger than the fragile roof in pemphigus. Can you give us the keywords for this condition?
Of course. Keep your eyes out for the following presentation. It usually affects elderly patients and the blisters are tense, dome-shaped bulla, usually around 2 to 4 centimeters, but they can get as large as 8 centimeters. They can appear on either normal skin or on top of erythema. Also, the pruritus can be pretty intense. The most common spots are the inner thighs, flexor forearms, axilla, groin, and lower abdomen. Mucosal involvement does happen, but it's less common and much milder, only about 10 to 15%, and it usually shows up after the skin lesions, unlike pemphigus vulgaris, which usually starts as mucosal involvement begins.
Okay, so how about we zoom in on it under the microscope?
Sure thing. Histologically, you will find a subepidermal non-acantholytic blister. Basically, the entire epidermis lifts off in one piece, and there aren't any acantholytic cells floating around inside, because the epidermal cells themselves are still attached to each other. It's just that the lowest layer is not attached to the basement membrane. Early on, you'll spot basal cell vacuolization at the dermo-epidermal junction, some dermal edema, and a superficial perivascular eosinophilic infiltrate, along with some lymphocytes. What's cool is that sometimes you can actually see eosinophils degranulating just under the epidermis, which contributes to the damage.
So subepidermal blisters with eosinophils, without any tombstone or acantholytic cells floating around.
In short, yes. When you do direct immunofluorescence, in this case, you see a smooth, linear band of IgG and complement C3 along the basement membrane zone.
That sounds super high yield. When we saw fishnet IgGs between cells, that was pemphigus. But here, it's linear IgG along the basement membrane for bullous pemphigoid. How do we manage these patients? Is it also by immunosuppressive therapy like we did for pemphigus?
Yes, since it's also autoimmune, we use immunosuppressive therapy, especially systemic corticosteroids and sometimes other immunosuppressants to dampen the autoimmune attack. The prognosis is generally better than pemphigus vulgaris since bullous pemphigoid tends to be less fatal. Think of the tense blisters in bullous pemphigoid as strong enough to not rupture and kill you, unlike the weak blisters in pemphigus, which are more prone to fluid loss and infections.
Okay, so let's take another quick question for our listeners. An elderly patient presents with pruritic tense bulla. The mucosa is mostly spared and biopsy shows subepidermal non-acantholytic blisters and lots of eosinophils. What would the immunofluorescence show?
That's bullous pemphigoid, so you would find a linear band of IgG and C3 along the basement membrane at the dermo-epidermal junction.
Before we leave the pemphigoid family, there's one more related condition we should mention, kind of like the scarier cousin of bullous pemphigoid.
Yes, this one is called cicatricial pemphigoid, also known as mucous membrane pemphigoid. It's very rare and it mainly targets the mucous membrane rather than the skin.
And why is it called the scarier cousin? What makes it so concerning?
The chronic inflammation causes scarring, and that scarring can lead to major complications, especially in the eyes. If the conjunctiva keeps scarring, patients can actually go blind. So this one isn't just uncomfortable, it can cause real long-term damage.
Oh, I see. And who's at highest risk of developing this disease?
Usually middle-aged to elderly adults, and it's more common in women. The pathogenesis involves IgG autoantibodies against basement membrane proteins like BP180, laminin 332, and type 7 collagen, so kind of a combination of what we saw in other bullous diseases.
So different targets, but still in the basement membrane zone territory.
Exactly, and depending on where the damage worsens, you get different types. There's ocular mucous membrane pemphigoid, where the conjunctiva scars. There's oral mucous membrane pemphigoid, where you get gingival erosions. And skin involvement does happen, but it's actually pretty rare.
So this one really needs early treatment.
Yes, immediate treatment is crucial to prevent scarring and the long-term morbidity that comes with it. Definitely want to catch early.
Alright, now that we finally met the scary cousin, we can move on from the pemphigoid family once and for all. Now we'll shift to a disease with a more dramatic name, dermatitis herpetiformis. Is it somehow related to the herpes virus?
I see why you would think so, but no, it's called herpetiformis because the vesicles are grouped. Kind of like herpes lesions, but it's actually an autoimmune condition that's closely linked to gluten-sensitive enteropathy, basically celiac disease. You tend to see it in young to middle-aged adults, and it's more common in males, especially in the 3rd to 4th decade.
And how would this patient present in the clinic?
Patients have intensely pruritic symmetrical urticarial plaques with clustered vesicles. Their favorite spots are extensor surfaces, so the elbows, knees, upper back, and buttocks. And because it's so itchy, you often see more excoriations and crusts than perfect little blisters.
But we're talking about the skin, so where does gluten come in?
In celiac patients, eating gluten makes them produce IgA antibodies against gluten-related antigens in the gut.
And I'm guessing these antibodies escape the gut?
You're right. Some of them cross-react with parts of the skin, especially the reticulin fibers and the dermal anchoring structures. They form granular IgA deposits at the tips of the dermal papillae, which then pull in neutrophils, and that's where the classic histology comes from.
So, IgA deposits at the tips of the dermal papillae plus neutrophils. Let us walk through it step by step.
Early on, you'll see small collections of neutrophils and fibrin at the tips of the dermal papillae. If you ever see the term microabscess, this collection of neutrophils is what they're referring to. And because in this case the collections are at the dermal papillae, we call them papillary microabscesses. The basal keratinocytes above them start to vacuolize, and as this process continues, those tiny vacuoles and little separations merge together and form a subepidermal blister. So just like in bullous pemphigoid, the blister ends up being subepidermal, but the inflammatory pattern and the immunofluorescence findings are different.
So far, we've got IgA deposits and microabscesses, all happening at the dermal papillae, leading to subepidermal blisters. But we can't forget the fan favorite, immunofluorescence.
I got you. On immunofluorescence, you see granular deposits of IgA in a discontinuous granular pattern at the tips of dermal papillae. Think of the letter A resembling a tip, and be careful in this case. It's IgA, unlike the previous group of diseases where it was IgG.
So, let me get this straight. Whenever we see itchy blisters on extensor surfaces in a young person who has celiac disease, we immediately think of dermatitis herpetiformis. And in histology, we see subepidermal blisters with neutrophilic microabscesses and granular IgA deposits at the tips of the dermal papillae.
Yes, sir, you're absolutely right. And clinically, it improves dramatically with a gluten-free diet, often with additional medication like dapsone for symptom control.
So, we manage the underlying celiac disease, and the blisters would go away on their own. Okay, Naya, now we're done discussing autoimmune blistering diseases. Good job. Let's move on to inherited blistering diseases.
Right, that's where epidermolysis bullosa comes in. Epidermolysis bullosa, or EB, refers to a group of conditions where the skin is extremely fragile because the structural proteins that should keep the layers together are genetically faulty. So instead of antibodies attacking the glue, here the glue itself is faulty from the factory.
Since the mechanism of the disease is different, I'm sure clinical presentations must be different too. Tell me about it.
Patients, often infants or young children, develop blisters at sites of minor trauma or pressure like rubbing from clothes, minor knocks, or even just carrying them. The pattern and level of blister depends on which protein is mutated.
Oh, I know. There are 3 major types, based on the protein that's defective.
Yes, the first is EB simplex, where the problem is inside the basal keratinocytes of the epidermis.
So the problem is simply within the cells themselves. See what I did there?
That's a good one, Seedra. In this case, the mutations in keratin 5 or keratin 14, the intermediate filaments that make up the cytoskeleton of basal cells, make those cells fragile. So with even milder mechanical stress, the basal cells rupture, and you end up with an intraepidermal blister right in the basal layer. The dermis and the basement membrane stay normal, and there is usually very little inflammation.
Next up, we have junctional EB. Is the name a giveaway?
Very much so. In junctional EB, the blister forms at the level of the lamina lucida, which is part of the basement membrane zone. So the split is at the junction between the epidermis and the dermis. The problem is in proteins like laminin 332, laminin 5, and alpha 6 beta 4 integrin, which connect the epidermis to the basement membrane.
Whoa, slow down there. Is there an easier way to remember all these proteins?
Yes, basically I use this rhyme. 332 is the glue, 64 is the door. Laminin 332 is the glue that sticks the layers, and alpha 6 B4 integrin is the doorway connection into the basement membrane. Break either one, and boom, you have a blister.
So 332 is the glue, 64 is the door. Oh, I like that.
Yeah.
And last, but definitely not least,
Dystrophic EB. Here, the split is even deeper, beneath the lamina densa in the upper dermis. In dystrophic EB, the mutation is in COL7A1, which encodes type 7 collagen, the key component of anchoring fibrils. Those fibrils are what secure the basement membrane to the underlying dermis.
that does sound pretty bad. Can you tell us more?
Okay, basically, because the anchoring fibrils are defective, even minor trauma causes the skin to separate below the basement membrane. And with repeated blistering over time, you can get scarring. And unfortunately, that increases the risk of squamous cell carcinoma developing in chronic, non-healing ulcers.
So now that we've covered all three types, which were EB simplex, junctional EB, and dystrophic EB, how can we tell which type of EB it is? Can we see it on biopsy?
The histologic changes in EB can be subtle, and sometimes you actually need electron microscopy to pinpoint the exact level of the split.
So if you want to summarize EB, these patients have mechanically fragile skin from birth, forming blisters at trauma sites. The level of the split depends on what protein is mutated, giving us different subtypes of EB. And generally, EB is not inflammatory, unlike the autoimmune ones we discussed before, because EB is all about the proteins being structurally abnormal and nothing about the antibodies.
Allah alayki, that's exactly how it is.
Okay, Naya, before we sign off, let's do a quick recap so our listeners can easily remember all the high yield points we've mentioned so far. Are you ready for a speedrun?
Always. So starting from the top, we said the skin is layered as epidermis, basement membrane zone, dermis, and then subcutaneous tissue. And blisters basically form when the glue between any of these levels fail.
And inside the epidermis, the glue is made of desmosomes, which use desmoglein 1 in the upper layers and desmoglein 3 in the deeper layers of mucosa. That's what explains why disorders that target desmoglein 3, like Pemphigus vulgaris, love attacking the mouth.
Exactly. And once we reached the basement membrane zone, we listed all the important players. Hemidesmosomes and BP180 in the lamina lucida, laminin 332, and type 4 collagen in the lamina densa, and type 7 collagen anchoring fibrils in the sublamina densa. That whole structure is the reason pemphigoid and EB behave the way they do.
Then, we took a detour into the language of dermatology, and we talked morphology. Primary lesions are what the disease originally presents with, things like vesicles or bulla, and secondary lesions are what happens after scratching or rupture, like erosions and crusts. We also said a vesicle is under 1 centimeter, while a bulla is above 1 centimeter, and the word blister is just a casual term for either. And don't forget the bedside clues. Nikolsky sign is where applying pressure makes the epidermis peel, and the Asboe-Hansen sign is where pushing the blister makes it expand. Both point towards pemphigus.
And we clarified that not every blister equals a bullous disorder. Things like impetigo, herpes, burns, or simple trauma can blister too, and even are more common. But the real bullous diseases are the autoimmune ones and the inherited ones. And the level of blister helps you know which group you're dealing with. Subcorneal or intradermal blisters suggest a desmosome problem like pemphigus, while subepidermal blisters point toward basement membrane zone problems like pemphigoid, dermatitis, herpetiformis, or EB.
Which brings us to Pemphigus vulgaris. We said it's autoimmune IgG against desmogleins, especially desmoglein 3, leading to suprabasal intraepidermal blisters with acantholysis and that tombstone basal layer. Clinically, they get flaccid blisters, mucosal erosions, and positive Nikolsky and Asboe-Hansen signs. And on direct immunofluorescence, you get that classic fishnet appearance.
And then we meet the rest of the Pemphigus family. Foliaceous is superficial and spares the mucosa. Vegetans forms vegetating plaques and flexures. Erythematosus is localized and malar. And paraneoplastic is associated with malignancies like non-Hodgkin lymphoma.
Then we flip to bullous pemphigoid, which we described as tense bulla in elderly patients with IgGs against hemidesmosomes and basement membrane antigens, creating subepidermal, non-acantholytic blisters full of eosinophils. On immunofluorescence, we see linear IgG and C3 along the basement membrane.
And right next to it is the scarier cousin, cicatricial pemphigoid, which mainly attacks mucous membranes and causes scarring, especially in the conjunctiva of the eye, which can lead to blindness if not fully treated.
Then came dermatitis herpetiformis. We talked about how it's linked to celiac disease, gives intensely itchy grouped vesicles on extensor surfaces, and forms papillary microabscesses of neutrophils, with granular IgA deposits at the tips of dermal papilla.
And finally, Epidermolysis bullosa, the inherited group, where the glue is faulty from birth. EB simplex involves keratin 5 and 14 inside the basal cells. Junctional EB affects laminin and integrants at the lamina lucida in the basement membrane. And dystrophic EB is all about defective type 7 collagen, leading to deeper blistering and scarring.
So, if we were to compress all of that into a diagnostic cheat code, flaccid with mucosa and fishnets means pemphigus, tense with linear IgG means pemphigoid, itchy extensors mean dermatitis herpetiformis, and trauma blisters in infants point towards EB.
And honestly, once you understand the skin layers, the adhesion proteins, and the morphology language, all of these patterns suddenly click into place.
Perfect! Now we've finally earned our outro. And that wraps up our episode on bullous skin disorders. Thank you guys for sticking around through all the layers.
Thank you all for tuning in. And now, before you guys leave, we've prepared a little surprise for you. Are you
Yalla.
ready, Seedra?
3, 2, 1.
Pairs on the mic make a skin talk slick. From bumps to blisters, we break it down quick. Derm on the beat, knowledge to share. PodBites forever stay smooth like a pear.
I'm so sorry, guys. See you in the next episode of PodBites.
Whoosh.
Wish.
That's a brilliant way to put it. In Pemphigus vulgaris, no. Do I remove that's a brilliant way to put it?
It is a brilliant way to put it.
Is it cringe?
No.
Okay.
What's the diagnosis?
The diagnosis is, can I have a drum roll, Seedra? Pemphigus vulgaris.
That was the end of the segment. That was the end of the segment.
Say,
Okay.
all right, read the next. Yes, these are super practical. Yes, these are super practical. The Nikolsky sign. Nikolsky. Yes, these are super practical. The Nikolsky sign is when you apply gentle lateral pressure.
Repeat من عند Nikolsky.
Nikolsky.
Yes.
Not. It was a sign.
It's a sign.
Nikolsky.
Yes.
Okay.